Good evening, everyone. Yeah, welcome to the live surgery, Dentium. Uh, it's 7 p.m. in Korea. I don't know what time it is in your country. So we prepared today a very interesting case and valuable case. You can use it in your daily practice. Uh, everybody know that's Dr. Lee. He has Teddy Lee. He has been showing a lot of live surgery so far. So today's case is about the posterior tooth extraction and the immediate implant placement. So I hope you enjoy and I hope you get a lot of lesson from the live surgery. Let me start the surgery. Let me start the brief introduction of live surgery. Before starting my presentation, my name is Seung-Keun Kim, today's moderator, working for the Seoul National University, Department of Periodontology, and also administrating the continuing education in Seoul National University. So let me start the case preview. Today's case is immediate implant placements after tooth extraction on the mandible. The one premolar and the one molar. So number 45 and 47, we're going to extract the tooth and we're going to place the implant immediately. This is patient information. 43 male patient presented to the clinic with a cheek complaint. The gums are swollen and bleeding from the lower right. And as a past dental history, he has available loss in the number 47, and present illness not available for now. This is today's surgery plan, number 45 and 47. We're going to extract the tooth and the immediate implant placement. Especially for today's case, we're going to use bright implant for regular size. One is the 4.0 diameter and the other one is 4.5 diameter. And we're going to do the simultaneous approach with GBR. So if you look at the panoramic radiograph, you can figure out the number 45 is distally angulated and the number 47 is medially angulated. Hopefully, we're going to extract without any problem with the extractor tooth, and we're going to place the implant in this direction. So, direction of the implant placement is a little bit different from the tooth axis, which means we can get a lot of pressed ball we can use for the primary stability. Sometimes this angulate tooth is good for the immediate implant placement. And we're going to use the bone graft, genogenic bone graft, osteogenic, and collagen membrane, and increasing the thickness. We're going to use the collagen graft, collagen matrix, and also collagenated bone graft will be used. Nowadays, we are applying the combination of the particulated bone graft and the collagenous bone graft. For the collagenated bone graft is good for the, making space and, it's manipulating and maintaining the contour. And some other part, we also using the particulated bone graft. So nowadays, the combination of the collagenated bone graft and particulated bone graft is popular in Korea. So also, if you get the good initial stability, we're going to use the immediate connection of the healing abutment. This is a CT view. With panoramic radiograph, we also evaluate the other side, left upper. It looks like a superline implant dentium. As the implant we are using today, bright implant, is a little bit different from this implant. It will be interesting that after the placing implant, we're going to take the radiograph so you can compare the radiography image of bright implant from the superline implant. 45. So actually, when you are placing implant, buccal-ringal relationship, we are placing implant, we have to evaluate where the large amount of the bone is located. So I don't think we don't have any problem placing implant in 45 and aiming axis of the implant, aiming the functional cusp, inner incline of functional cusp of the opposing dentition. So axis is like that. But 47 also placing implant in this way. However, there's something we have to be very careful. If you follow the direction of this axis of tooth, you're going to perforate the lingual cortex. So you have to be careful when you're placing implant. You don't have to place the long implant. So sometimes even though there's enough distance from the mandibular canal, there's a risk of perforating the lingual plate. Therefore, I think a short implant is recommended, and also you don't have to follow the axis of the tooth for the immediate implant placement. This is a clinical photo. It's defective restoration, and you can see some inflammation of the gum and also some bone loss. The similar case, I'm going to show the similar case, but this similar case has, the axis of the tooth is exactly perpendicular to the occlusal plane. Therefore, I think the ideal axis of the implant placement is just following the extraction socket. Therefore, it'll be very good if there is enough space, enough bone between the apex of the root and the mandibular canal. But I don't think that there is enough bone between the apex and the mandibular canal. So when you're placing implant on the second molar, we have to be very careful not damaging the inferior alveolar nerve. So, and the direction will follow the axis of the tooth. So this is the after extraction, and just follow the axis of the root tooth, and successfully got the initial stability, and in the middle, the lingual bone and the buccal bone, and some part of the apex. So this is the similar case after immediately placement of implant after tooth extraction. So, and also you can find find the video also following this link, and also use some healing abutment like this. Some people like using also Dr. Lee likes using the healing abutment with the large diameter like this. In this case, we don't have to use the barrier membrane. After immediate implant placement, there's gap defect around because size of the extraction socket is bigger than implant diameter. Therefore, there should be some space between implant and the bone. So we have to fill in the bone graft material inside, and also we need some barrier membrane to secure the bone graft in the position. But if you choose the large diameter healing abutment, sometimes we don't have to use the barrier membrane. There's one advantage using this large diameter healing abutment. So this is the case after grafting, immediate implant placement, and the grafting and the healing abutment connection. Hopefully, we're gonna do the similar surgery and the healing abutment connection today. Okay, let's go to the clinic. Dr. Lee started the extraction procedure. This is the supracrestal fibrotomy. Yes, usually this procedure is also used for the orthodontic treatment, and so for this case, we are using the supracrestal fibrotomy for convenience, the convenience extraction procedure, and using the forceps. If this is the reason of extraction is periodontitis, so periodontal bone loss. Therefore, sometimes in this case we don't have to use the elevator and luxating with the forceps, buccolingual, and sometimes rotating, and got extract the tooth without any problem. As all we know, once some part of the tooth is broken, so it takes some more time. So we cannot concentrate the immediate implant placement. So extraction procedure with the minimal trauma is not damaging the surrounding structure is also important. And also safely, we extract the tooth without any problem. The number 47, or the forceps, sometimes the big, if this case is for the extracted for the period reason, but the other cases sometimes it's difficult to extract the tooth. Then we have to place the beak of the forceps as apically as possible to minimize the risk of the fracture. So in this case, simply Dr. Lee extract the tooth without any problem. And the next step is removing the granulation tissue with the curved surgical thread. The instrument we use, the supracrustal fibrotomy, is oval knife, as all you know, interproximal knife. So it's very useful using the cutting, the proximal tissue, and also used for the supracrustal fibrotomy. And after extraction, sometimes we don't have to open the flap. However, this case has some disease extraction socket with some inflammation. Therefore, probably Dr. Lee want to make sure the defect configuration, how it looks, and what we have to do. So for making the decision, I think Dr. Lee opening the flap. Sometimes before elevating the flap with periosteal elevator, so also organ knife, interproximal knife, could be used for the cutting a little soft tissue, especially interproximal area. And also elevating the lingual flap. Some people say that we don't have to open the lingual flap, but this treatment plan for this case is grafting the bone graft, grafting the bone after immediate implant placement. Therefore, probably Dr. Lee need some flap advancement for the primary closure. Because the extraction, after extraction, there is soft tissue is not enough for primary step, primary closure. Therefore, I think the flap advancement with the releasing incision would be required for the primary closure after augmentation. On buccal side, if there's some inflammation tissue, sometimes could be difficult for elevating the flap clearly. Therefore, because some irregular surface with bone and soft tissue. So one other lesion is checking the lingual side. Sometimes it's important how much of the bone loss was made on the lingual side. So if there is a bone loss also in the lingual side, the case would be very difficult because it means we have to do the vertical augmentation. But I think that in this case, the lingual plate is intact, so we don't have to do the vertical augmentation. So we have wall in the lingual side. It means grafting procedure is easier than the vertical augmentation. If there's no bone on the lingual side, sometimes we have to decide the grafting first and the implant placement later. It's the staged approach. But for this case, I guess Dr. Lee would get the primary stability without any problem, and also will successfully perform the horizontal augmentation without any problem. And removing the granulation tissue with the hemostat. And clearly, we can see the defect configuration and how much the bone loss on the buccal side, how it looks like on the lingual side. So it's very, very helpful deciding, what kind of bone graft procedure we have to do and what kind of barrier membrane we have to use. Sometimes we have to cut it. I have been using also. I like to use the hemostat to remove the granulation tissue. Sometimes we can use the blade or the sharp instrument to cut the granulation tissue out. So, the defect configuration becoming, you can see the clearly now because of open the flap after removing the granulation tissue, the bleeding is less than before. Therefore, we can see clearly the defect size and defect configuration. It's very important procedure. Let's say we place the implant on the granulation tissue. Can we get the ossea integration? Therefore, we need a thorough removal of the granulation tissue. And sometimes the straight curette, surgical curette is good for removing the granulation tissue, especially distal part of the extraction socket. So instead of using the curved instrument, Dr. Lee is using the straight surgical curette, and I don't see any more the granulation tissue. Probably there is inside a distal part of the number 44 on the premolar area. I cannot see, but Dr. Lee probably watching and removing the granulation tissue as much as possible. Delicate skill. I don't see any more granulation tissue, but he's keep removing, scraping extractions. Okay, it's important. It's very important for better result. Using some small tip, right? He's using smaller tip than surgical curette. Maybe looks like bone file. And keep using the saline irrigation. You can see more clearly inside of the socket. I think he is done with the, removal of the granulation tissue. And starting with the monocyte preparation for the immediate implant placement, using the Lindemann drill. As I mentioned, the number 45 angulated distally, so we don't have to follow that direction. We have to place axis of the implant should be perpendicular to the occlusal plane and parallel to the adjacent tooth. Therefore, we can get pretty much of the resting bone for getting the primary stability. I don't think he's using now the dewey extension. Sometimes when we are moving the handpiece, the adjacent tooth is in the way. In that case, we have to use the dewey extension. So otherwise, if you use the drill without dewey extension, the handpiece will contact with the number 44, and the axis of the implant is changed to distally. So sometimes you can see the implant is placed the distal axis this happen very often because the handpiece is contacting, you know, in the adjacent tooth. Then when the handpiece contact the adjacent tooth, the axis angulation of the implant changed. Therefore, he's using now the drill extension and continuing keeping the axis of the implant. It's parallel to the adjacent tooth and perpendicular to the occlusal surface. And also, if you see from the front, the buccal-lingual relationship, so he's doing very well. I think probably if the patient closes the mouth, the axis of the implant will be aiming the inner incline of the functional cusp of the adjacent, opposing dentition. Diameter 40, maybe he's going to use, he planned it to use it. So there's not many steps. 2 in the mandrill, and the next one, I think, is for the 4.0 diameter, for placing the 4.0 diameter implant. And I think he's changing. No, he's doing the bony site preparation for the molar area, 47. It looks like, I cannot see clearly. Yeah, I cannot see clearly, but it looks like bony site preparation number 47. The axis of tooth is mesially angulated, and the axis of the implant is parallel to the adjacent tooth. Therefore, we are not following the axis of the root. Instead, we are placing the implant parallel to the number 44 axis. And we don't need a drill extension for the number 47 because we don't have any adjacent tooth in the mesial side. When you are using the drill extension for when you are placing the posterior tooth, so it's good for not contacting the handpiece with the mesially located tooth. However, sometimes the patient has to open their mouth very wide. Therefore, if there is some problem with TMD, it's very difficult for patient to open wide. So sometimes we cannot use the drill extension for the placing when we are placing implant on the posterior side. In that case, we have to use the 2 different drill, short one, long one. We started with the short drill and drill it as much as possible, not touching in the adjacent tooth, and change the drill in the longer one and finish the drilling. So if patient is not able to open their mouth wider, then instead of using the drill extension, we have to use the 2 different lengths of the drill. And he's measuring I think it's a caliper, it's the instrument, measuring the distance of 2 bony site preparation point. As all we know, after placing implant, we have enough distance between 2 implants. Recommended distance is 3 millimeter. Therefore, when you let's say we are placing 4 millimeter diameter 2 adjacent implant, we have to distance between 2 implants 3 millimeter. Therefore, drilling point, distance from the drilling point is 7 millimeter, because of this side 2 millimeter, the other side 2 millimeter, and distance between 2 implants 3 millimeter. Let's say we have to place the 5 millimeter diameter 2 adjacent implant. Then we have the 2.5 millimeter, 2.5 millimeter, 3 millimeter. So therefore, we need a 8 millimeter distance between drilling point. So he was measuring the distance with caliper, the ruler. It's very, I think, valuable instrument for keeping the safe distance between implant. As all we know, when we have if the two adjacent implants is too close, I mean the less than 3 millimeter, there will be inevitably there will be some peri-implantitis and peri-implant bone loss. As researchers say, nowadays the distance is decreasing because we are using the internal connection type of implant and also some platform switching type. However, this safe distance between two implants is 3 millimeter. I always keep in mind when you're placing two adjacent implants. So he's done with the bone site preparation for placing implant now. I think now he's starting doing the flap advancement, respecting the bone graft, and also the augmented bone and membrane should be covered by the soft tissue. Therefore, we don't have enough soft tissue. It's using the blade and the releasing incision with number 15C blade carefully. You can see when he's doing the releasing incision on vocal side, it's not going deeper. We have to make a releasing incision about less than the 10 millimeter from the gingival margin, because there's one important anatomic structure, actually two important anatomic structure on this side, inferior labial artery in the posterior area. So if you go deeper on the posterior tooth area, you can damage the artery. And also in the medial side, there is the metaforamen. So he also checked the location of the metaforamen as not damaging the. And also, instead of making the vertical incision, I think it's one good way to make the releasing incision without any vertical incision. He used the number 12 blade and made enough flap advancement and checking whether the flap closure is made without any tension. I prefer using the vertical incision. Actually, it's not vertical incision. So oblique incision from the flap, actually the distal part of 44 to the maybe 43 or 42. And making the incision, then we can manipulate the flap easily, and also we can verify the location mental foramen. When you are making the releasing incision and the area of the mental foramen, first thing we have to do is verify the location of the mental foramen, and we have to make the dome shape of the releasing incision, minimizing the cutting the mental lobe. So two important kind of structure when you are making the flap advancement of posterior tooth area, inferior labial artery, and the mental foramen. And now he's placing implant. You see, he also using the long, installer because he don't never want to touching the medially located adjacent tooth. He want to keep Dr. Lee want to keep the axis without touching, without hand piece touching the adjacent tooth. And he got the enough torque, and probably he want to use the hand wrench. Yeah, and also placing the implant for 47. For immediate implant placement is always leaving the gap defect. So always we have to plan the bone graft simultaneously. Long time ago, there was some theory, the gap defect less than some certain size, we don't have to feel the gap defect. However, nowadays, everybody feel the gap defect, even though it is small defect. I think this he got the pretty much of stability, initial stability. 4.0 diameter implant was placed for the premolar area, and checking the depths of the implant is good way to use the dental mirror to the vertical location, to making sure the vertical location. And also the Dentium implant doesn't have any fixture mount, so checking the connecting the direction pin. Direction pin is connected with the hand. There's no instrument we can connect the direction pin, so we are using the finger. And I think it's pretty good, but I think he want to change the direction of the implant a little bit. Sometimes it can be changed when you and on screen, the reverse torque. No. Clockwise. Checking the depths I think it's pretty much good. If you see, look the on the front side, you can see the axis of the implant, the vocal lingual relation. Just follow the axis of the previous teeth, I mean the medial side tooth. I think the vocal lingual is ideally placed. And you know the immediate placement of the implant on posterior tooth area, usually you can see, I'm sorry, you can see the implant is moving a little bit and talking down when he's talking down. Because the immediate implant placement posterior tooth, we get the primal stability around the half of the implant, the apex side. The upper side, as all we know, there is a gap effect. Therefore, implant axis could be changed even during the talking down the implant. So we have to be very careful for the keeping the ideal axis of the implant. The one way we can make sure is probably he's gonna connect the direction pin again. If you don't have a direction pin, sometimes you can use the healing abutment. But anyway, we're gonna use the healing abutment for this case. If you connect the healing abutment, you can also see clearly the parallelism, whether the implant is parallel each other. So one best way we can make sure is you connecting the drilling pin and make sure putting the dental mirror in the lingual side. If you see from the outside with the dental mirror view, you can see clearly whether the two implant was placed parallel or not. If it is not, sometimes we have to change a little bit. The reason why the direction pin is moving, as I mentioned, is we're just talking down with the hand, with the finger. Therefore, it was not connected perfectly. That's why it looks like it's moving. But implant got pretty much of the primary stability, so we don't have to worry about it. So he's done with placing and connecting the healing abutment. The placing implant, the location of the platform is better placing two implants at the same level. However, sometimes it's not possible. But for this case, probably he's gonna build up the bone graft up to the healing abutment. Therefore, I think he will try his best to placing the top level of the top of healing abutment at the same level. It'll be more convenient, And also specially designed healing abutment he's using. I think he's using the healing abutment as as a space maintaining, for space maintaining. All the graft procedure, even for the soft tissue graft, there will be some shrinkage after some certain period of the healing time. Therefore, we have to over augment it, over contouring. Even though there is, let's say, the 30% of the shrinkage, even though there is a shrinkage during the healing time, at least we can get pretty much of the good bone up to the top of the fixture. That's the reason why we are building the bone graft more than we expect, because we have to expect the shrinkage of the graft. And also using the collagen membrane, Dentium collagen membrane, visible membrane. and trimming. Trimming procedure is important, very important. And also using the punch, membrane punch. I think he developed this device himself. If you want to ask about this instrument, you can send the email to Dr. Lee. He developed this instrument as using very open and very convenient. Because we measured, you remember, we measured the distance, the 2-point drilling point. Therefore, he already knows the distance between two implants. I mentioned he measured the distance because he want to keep the distance between implants. However, I think he measured the distance because he had to prep the membrane. So the hole, the healing abutment will be engaged in the hole. Therefore, he should have had to, measure the distance between two drilling points. Now I realized. Yes, there are several different ways we are stabilizing the membrane. My preference is using the suture for the stabilizing the bone graft and the membrane. Sometimes we use the bone tack with the collagen membrane, using the bone tack and stabilize the membrane, the bone graft, another bone tack on the ringer side. This is one best way, but we have to remove the bone tack for some day, so it's not easy. But if you see result, I think using the bone tack is a good way for the stabilizing the membrane. Also, we can use this kind of membrane punch, and we can use the healing abutment as a tool for the stabilizing the membrane. Once the membrane is engaged between the two healing abutments, I don't think it will move easily. So it's one good possible way for stabilizing the membrane. I mentioned that you can use the suture, you can use the bone tack, or you can use the healing abutment like this. And grafting the gap defect, I think this instrument has one side has some kind of flogger like this plugger, and the other side has a looks like big spoon excavator, and applying the bone graft to the defect. I think this instrument is also very convenient. He also using the healing abutment for space maintaining. I prefer the tent pole sometimes. If I were he, I'm gonna place some tent pole between two implants to maintain space. Maintaining space is very important. Otherwise, or we can use the titanium reinforced membrane to minimizing the risk of collapse of the membrane. So once after grafting, it's very important to maintain the space. Otherwise, the grafting material will be collapsed and healing like that. Then we can expect any, bone graft procedure, good result after bone graft procedure. Therefore, space maintaining is very good, and he's using the healing abutment as a space maintaining. The another way we can use the healing space maintaining is using the titanium reinforced non-visible membrane. But in that, if you use the non-resorbable membrane, we need additional surgical procedure to remove it. And also another disadvantage, he's using the collagenated bone graft. As I mentioned, sometimes it's very convenient for manipulating and maintaining some space better than, articulated bone graft. So one disadvantage we are using the non-resorbable membrane is once it is exposed, we cannot expect perfect, result. Because he manipulates the lingual side also, the lingual side, lingual flap advancement, it could get, primary closure successfully without any tension. You remember he made the direct flap advancement with the number 15C blade and the number 12 blade without any vertical incision and applying another collagenated bone graft. Another advantage of using the collagenated bone graft is prevent the particle dissipation. They, maintaining the control instead of participating, Some more releasing incision safely with the interproximal blade. But the lingual side, he never touched any sharp instrument in the lingual side. On the number 37 lingual side, there is a lingual lobe, so it's not recommended using the sharp instrument. Instead, he used the peristyle elevator for the advancement of the flap. As you see, the C is over-contouring the bone graft up to the level of the healing abutment. As I mentioned, even though there is some shrinkage of the graft material for a while, at least we don't have any bone loss on the implant shoulder area. That's why he's doing the overbuilding, over-contouring. Applying the membrane, the buccal side first. And engaging. The space is not enough. I guess the membrane is torn. It's okay, as long as the membrane is engaged on the one healing abutment on the number 47. I think it will be very difficult because the implant on the number 45 and natural tooth number 47, 42, 44 is not enough space between. Therefore, the collagen membrane could not be engaged without any tearing. So it was torn in the medial side, but it's okay. I don't think it has any problem. No problem. Probably now he's preparing the suture. I also, let me tell you later. Yeah, you can beautifully, he's saying that he doesn't like the stabilizing suture, but his preference, because instead he's using the stabilizing membrane with the healing abutment. I think it's a personal preference. My preference is using the suture for stabilizing the membrane. And another point that we have to concentrate is a good tip. The after suture, here is also using the matrix suture because the two side, lingual side flap and the buccal side flap, for the primary closure, they contact close. The contact area should be wider. So if you use just the interactive suture, this is just point between lingual flap and the buccal flap. But if you use the metric suture, I think vertical metric suture or horizontal metric suture, there's two surface, lingual surface from the lingual side, surface from the buccal flap, they contact each other. So contact area is becoming wider. So I strongly recommend, he strongly recommend the metric suture for the primary closure. And also, it's stronger than interactive suture. Therefore, sometimes during the healing time, the suture is it's got loose and flap was open. We can minimize their risk. Another metric suture, I think because he got enough stabilization of the membrane using the healing abutment, I think metric suture is enough. Yeah. There was the extraction socket. Soft tissue was not enough for primary stability, but he used let me tell you, he used the flap advancement and he successfully made primary closure. And also, I think he's using the collagen matrix to cover the. Let me see. I think he has enough, flap for primary closure. Probably he's applying the collagen matrix, whereas worrying about some exposure, worrying about not getting the primary stability maybe. I think he got already primary enough flap from the primary closure. Let me tell you after he's done. Looks like he's doing the open membrane technique. Open membrane technique. Maybe it'll be closed. Yeah. I think he applied the collagen matrix in case. Even though he got the primary closure with the flap advancement, he want to make sure. So he want to prevent the, flap is open and the bone graft is not secured in the position. And also he want to increase the thickness of that area of soft tissue. That's why he applied the collagen matrix. Or he doesn't want any exposure of healing abutment. Therefore, he applied the collagen matrix that side. Yeah, that's pretty much of the amount of the flap for the primary closure. Yeah, there is some report, some scientific report use, reporting, there is some advantage using the two layer of the membrane, especially when you are using the titanium mesh. It's recommended using the another layer of the collagen matrix to minimize the exposure of the membrane. For this case, I think he successfully got the primary closure with the flap advancement and applying the two layers of membrane because yeah, she probably Dr. Lee want to prevent the membrane exposure or the healing abutment exposure during the healing procedure. Yeah, some auxiliary suture with the interrupted. Yeah, between the vertical matrix suture. He made the two vertical matrix suture, and in between, he using the interrupted suture. Almost done. Yeah, he's applying the PDRN. It's now available and popular in Korea. So it's good for cell growth and angiogenesis and the tissue oxygenation and anti-inflammation effect. So usually commonly extracted and purified from gonads of salmon trout. So for yeah, PDRN is nowadays available in Korea and it's very popular for the healing advancement. Yeah, it's done and the checking and the breathing control with pressure and he's taking the radiograph. Yeah, he successfully extracted tooth without any trauma and placed the implant in the ideal axis and got the primary stability without any problem and filled the gap effect and flap advancement and he got the primary closure. He and also applied the membrane, collagen membrane, and one layer of a collagen matrix to minimizing the risk of the membrane exposure or healing abutment exposure. he used the healing ointment for stabilizing the membrane. He found out that one reason was just bleeding. There's some flap opening on one side, and found out and doing the last suture, interrupted suture. Yeah, he's done. He almost done. Controlled the bleeding successfully. One more, one more suture. Yeah, probably. Hopefully, this will be the last suture. Yeah, he's done. So we extract the tooth and place the implant immediately and doing the bone graft successfully and flap management and got the primary closure and the bleeding control that beautifully performed. So we're gonna start again the Q&A procedure after 10 minutes. Meantime, he's taking the radiograph after the surgery, so we can compare the before and after surgery with the panoramic radiograph. Yeah, we'll see you after 10 minutes. Okay, thanks, Dr. Lee. He took the radiograph and found out the implant was successfully placed, even though the level of the implant fixture could not be at the same level as I mentioned, because we have to place the at the level of the crestal bone. But he did his best, making the with changing the length of the healing abutment. Therefore, this level, you can see the arrow, the mouse. You can see the level is at the same level. The top of the healing abutment is good for the maintaining the flap easily. And he filled the bone graft up to the top of the healing abutment level and use the collagen membrane. So as I mentioned at the beginning, on the 47, you don't have to place the long implant. You can see that there's pretty much of the space between the apex of the implant and the mandibular canal, but the axis of the implant, if we use the long implant, sometimes we can break the lingual plate. It's not good. So I think that the length was ideal for the implant in the 47, and the 45 also pressed well, and didn't damage any mental foramen in this area. And the tooth axis looks like this, mesially angulated, 47, and 45 distally angulated. The implant was placed parallel to the adjacent number 44. So, and perpendicular to the occlusal plane. And you cannot see the buckling relationship, and perfectly aiming the inner incline of the functional cusp of opposing dentition. And it's a beautiful case. So this is it for the today's case, and we can have time for the Q&A. Yeah, he used a different implant, bright implant from Dentium for extraction socket, and advantage I'm going to explain with the radiograph. So you can see the shape of the implant is different. This is bright implant. This is a superline implant with Dentium. This bright implant is good for the immediate implant for getting the primary stability, because three reasons. One is fixture shape, and the other is surface area, and last one is thread design, fixture thread design. If you see it, the middle of the fixture looks like dome shape. It's bulky. It's good for getting the primary stability. Better than, the superline is very good implant. My favorite implant is a tapered implant, but you can see the bright implant in the middle is a little bit bulky. Therefore, we can get the primary stability better than the superline implant because of dome shape of the fixture shape. And the other one is surface contact area. Because of this shape, surface contact area is increased. Therefore, we have more chance for getting the primary stability. The third one is thread design. If you see carefully, the thread design of the bright implants is more aggressive than the superline implant. Therefore, the initial stability could be obtained more easily than the superline implant. Three reasons: fixture, dome shape fixture, and the surface area was increased, and the other aggressive thread design. These three reasons is good for the immediate implant placement for getting the primary stability in the limited bone amount. But there's the advantage of bright implant. And also bright implant, two different type of the design. The one is tissue level. This is the internal connection type of the implant. Advantage, they change the design. They change the two design. Sometimes in the posterior tooth area, the recommendation was placing the wide diameter implant long time ago. However, the strength was increased is bright implant. I mean the thick, the wall of the fixture wall, the outside, the thickness was increased. And also The two reasons: the thickness of fixture increased, so minimize the risk of the fracture of the fixture, and the other one is the connection became the stronger, so deeper and the ideal connection taper, therefore the preventing the fixture 아니 abutment loosening. So two advantage of the internal connection of type of the bright implant. One is to increase the thickness of the fixture wall. The other one is the ideal connection type with the longer. So usually it's 2.5 millimeter connection depth, but this was 3.7 millimeter connection depth. So the internal type of the bright implant, two advantage. One is thickness of the fixture increased, and the other is the connection. That's the advantage of the bright implant. And I think there's no more question about that. So thank you for your time, and thank you for your concentration for the live surgery. I hope you enjoyed the live surgery, and also everyone got the lesson from the lesson which you can use for your daily practice. Thank you for your attention. I think have a good night. Now Korea is 8 p.m. and have a wonderful evening, everyone. Thank you for watching.